Yes, ma'am.
Can you hear me?
Yes, ma'am.
Why is the virtual background coming inverted? Just check that.
Okay, ma'am.
IAIO is coming inverted in my virtual background.
Hemant sir, shall we start at 6:30 p.m.?
Yeah, we'll start. We'll start at 6:30. Sure.
Okay, sir. So, good evening, everyone. I warmly welcome you all to today's session on IAIO Expert Insight Gastrointestinal Cancer. On behalf of the International Association for Integrated Oncology, it's my pleasure to welcome all our esteemed faculty and participants to today's academic session. Today, we have an esteemed panel of experts from various oncology specialties who will share their valuable knowledge and clinical experience. Let's begin the session. It's my privilege to introduce our program director, Dr. Hemant Muthuluri, consultant medical and hemato-oncologist, KIMS Hospital, Ongal, Andhra Pradesh, to deliver the introduction and context setting. So, over to you, please.
Thank you. Good evening, dear colleagues and seniors. It's my pleasure to invite you all for the today's discussion, expert insights on the colorectal cancer. I thank IAIO and team for setting up this stage and bringing us all together for this today's event. Today, we'll try to discuss the management of rectal cancer right from the basics to the advanced treatment options. In brief, in a curative setting, the available treatment options may not have changed significantly, but the uncertainty still remains regarding the best sequence of treatment. Through today's expert discussions, we hope to identify the most appropriate sequence for the most appropriate patient. In the same way, in the metastatic colorectal cancer, especially in the RAF and RAS mutated setting, there are several new developments that are changing the landscape. Today, we will try to understand the best possible treatments based on the current evidence while looking ahead to future perspectives. With this brief introduction, I will now hand over the session to IAIO to invite our first speaker, Dr. Indu Menu.
Thank you, sir, for setting the context so effectively. It's my pleasure to introduce our first speaker, Dr. Indu Vanshal Agrawal, Group Director and HOD of Radiation Oncology at Paras Health, Gurgaon, Haryana. Ma'am, over to you.
Hi, good evening, everyone. Am I audible?
Yes, ma'am, audible.
Okay, thank you. Good evening, everyone, and it's really a pleasure for me to be delivering this talk on role of radiation in rectal cancers, and I really want to thank Dr. Hemant and IAIO for this expert session on expert insights in gastrointestinal cancer. Can I share my slides, please?
Yes, ma'am.
Yeah, give me 1 second to share my slides. Yeah. Yes. Are my slides visible?
Yes, ma'am, visible.
Okay, thank you. So over next 15 minutes, I will be talking about the role of radiation in rectal cancers, and the different areas that I would be covering would be uh, important areas that we need to look into, or the things that even a medical or a radiation oncologist must understand if they want to plan a case of a rectal cancer. When to, and I am 100% sure that after I finish my talk, you will understand which patient to offer not to offer radiation, which patient can be kept for wait and watch strategy, which patient needs chemoradiation, and which patient needs total neoadjuvant chemotherapy. So before we plan any patient with rectal cancer, there are certain things which are very, very important to understand, and you can remember that by a mnemonic, which means rectal cancer. So if you see this, R means you have to see through the medical records of the patient, do a thorough rectal examination, do an endoscopic evaluation. You must know whether the patient has undergone a biopsy, a local resection, any chemotherapy, radiation, or surgery, and what was the previous pathology report. Then you have to see the MRI sequences, and you have to see T1 contrast, T2 contrast, star images, and all the images of MRI. And this, you need to really spend some good time on evaluating the MRI sequences, because on MRI, we have to see where is the tumor, where is the most invasive border, where are the elevated borders, and does it have any mucoid material inside the lumen? Or we have to see the shape of the tumor, the location of the tumor, its extent in the craniocaudal direction, whether the tumor is located in the upper rectum, mid rectum, or lower rectum, at which position, 6 o'clock position, from 2 to 5 o'clock position, or all. What is the length of tumor? Its relationship from the anorectum, how much above it is from the anal sphincter and anal verge. Then you have to see about the T stage, appearance of the tumor, then location of the tumor, I told you. Then CRM status. CRM status means circumferential margin, is very, very important. And how to study that I'll tell you. You have to, if a patient has received radiation chemotherapy before, then you have to analyze the prior MRI images, end stage, and which nodal volume is involved. Is it inside the mesorectum? Is it outside the mesorectum? Is it the lateral rectal nodes? All those areas are very, very important. And then we have to see what is the sphincter complex status. So is the tumor involving the internal sphincter, external sphincter, or what? And then extramural venous invasion status. And if patient has received chemotherapy before, then what is the tumor regression? So mesorectal fascia, basically it's a low signal intensity line which is surrounding the mesorectum. So this, you can see this area, which is this area of fat around the rectum is the mesorectal fascia. This is the line that separates the mesorectum from the surrounding structure. So this mesorectum is the fatty tissue which is surrounding the rectum, and the fascia which separates it, that is the mesorectal fascia. Then you need to know what is an anorectal ring, anal verge, and all. I can't go into the details in a 15-minute session. Now, this is also something which is very, very important. You need to know whether the tumor is in the upper rectum. Is it primarily a sigmoid cancer, or it's a rectum cancer going to sigmoid? So how do we identify that? So there is something which is known as sigmoid takeoff. So what does it mean is that when the sigmoid turns away from the sacrum, this is how you see it. See, you can see this. This is the area of sigmoid takeoff. So tumors above it would be the sigmoid tumors, and or on this image you can see when the sigmoid projects ventrally. Then similarly, you have to understand what is an anorectal junction. So where the puborectalis muscle contracts, it is located at the anorectal angle. That is the anorectal junction, and it's always better to put a wire at the anal verge so that you know understand where the tumor is. And if you can put a marker at the lower end of the tumor before doing your radiation planning at the time of simulation, it would be very, very important. Then invasive margin is the tumor's attachment. It is the site where the tumor invades beyond the rectal wall. And at this point, you have to see the CRM, and it is critical for T staging and for assessing the extramural extension. Then mucinous tumors are basically, they appear bright on T2 weighted images as compared to a non-mucinous tumor. But mixed tumor may have both bright as well as dark signals. Then mesorectum, we have to, while contouring the mesorectum, we have to see the boundaries, and please take out your atlases when you start contouring, understanding the mesorectum, because mesorectum you have to completely cover the mesorectum. As a surgeon removes, they do a total mesorectal excision, so they are removing whole of the mesorectum. As a radiation oncologist, we have to cover whole of the mesorectum. Then sometimes there is people confused between what is a mesorectum and what is an ischiorectal fossa. So if you can see this, this is the rectum. This is a patient lying in the prone image, and this area of the fat where the this area, this is the mesorectum, and this triangular area is the ischiorectal fossa. So internal obturator muscles and the gluteus maximus muscles, they cover it. So this is the ischiorectal fossa. Now, MRF and EMVI are very, very important. So what do we mean by mesorectal fascia involvement? So MRF is involved if there is, if you can see this, this is the mesorectal fascia. And so if there is direct invasion of the tumor into the mesorectal fascia, so if there is less than 1 millimeter margin from the primary tumor, if there is extramural venous invasion or tumor deposits or irregular lymph nodes, it means these are nodes with an extracapsular extension. So in the mesorectum, we look out for this CRN, extramural venous invasion, as well as the tumor deposits. So any smooth lymph node without irregular margins is an exception. It does not classify as a mesorectal fascia invasion. So MRF is seen on radiology, while the CRM is the actual surgical margin created during TME, which is assessed by the pathologist. Then extramural venous invasion is when a tumor invades the surrounding blood vessels, as you can see here. And there are 4 grades, 0, 1, 2, 3, 4. Grades 3 to 4 should be reported as extramural venous invasion positivity. Then lymph node map is very, very important because the mesorectal nodes, that is the high mesorectal nodes, they go right up to the inferior mesenteric artery. They are located along the presacral, inferior mesenteric and superior rectal vessels. So mesorectal nodes, the obturator nodes, and the internal iliac nodes, they are considered as regional nodes. While the common iliac nodes, where is the cursor? While the just a second. While the common iliac nodes, external iliac nodes, and inguinal nodes, as you can see here, they are considered as non-regional nodes. And what are lateral nodes? So lateral nodes are the obturator, internal iliac, and inguinal. So if these nodes are involved, then it is a short indication for TNT. So please look carefully which nodes are involved, because tender TMA removes only the mesorectal nodes, while the obturator and internal iliac nodes are not routinely excised. And the inguinal nodes, if the tumor is in the distal anal canal, they are considered as regional nodes, and they are not considered as external nodes for a lower distal anal canal cancer. Now, these are the different, I'm not going into the details of surgery. So now coming to treatment. So staging and treatment overview. This I've tried to simplify it as much as possible. So for stage 1, that is T1, T2, N0, M0, there is, if it's a proper TME or a proper surgery, then there is no need of radiation. But if it's a stage 2 tumor, that is T3, T4, N0, then we give radiation plus minus chemotherapy, and surgery is total mesorectal excision, and RT is used for selective cases. While if it's a stage 3 tumor, T1 to T4, node positive, these are the difficult group where you have to decide whether you have to give only chemoradiation or you have to give total neoadjuvant, total neoadjuvant treatment. So this category is a difficult group where you basically need to understand, and this group definitely needs radiation. Stage 4 means with metastatic disease, and the radiation is individualized and it has to be decided on a case-to-case basis. So key principle is that MRA is mandatory for staging. We have to see for the tumor height, CRM status, extramural venous invasion, and nodal status. Now, there is a risk stratification to decide which patients need what treatment. So, it's like a traffic light. So if a good risk patient, that is T1, T2, N0, tumor more than 10 to 12 centimeter above the anal verge, clear mesorectal fascia, or selected high rectal T3A, B, N0 with clear CRM, no extramural venous invasion, no lateral nodes. So often surgery alone is sufficient and RT and chemo may be added, but RT can be omitted. While very low tumors, like less than 5 to 6 centimeter from the anal verge, any patient with extramural venous invasion, any patient with tumor deposits, and threatened but not frankly involved CRM, they are indications for neoadjuvant treatment. So you can give a local long course chemo radiation for this bad risk group of patients. So what do you mean by threatened and involved CRM? Involved CRM means when the circumferential resection margin is within 1 millimeter. If it is between 1 to 2 millimeter, then it is considered as threatened. And if it is more than 2 millimeter, then it is considered free. Now, what is an ugly risk? Risk patients need TNT because these are the patients with CT4AB positive or frankly threatened mesorectal fascia, N2 disease, bulky nodes, multiple nodes, or if there is a lateral pelvic node involvement, or there are high risk features for distant failure. For example, if there is extramural venous invasion with high nodal burden, or it's a CT3C or D tumors. So this group definitely benefits from TNT. Now, what are the absolute indications of radiation? So again, if it's a T4AB tumor, which is tumor invading the adjacent organs, bladder, prostate, uterus, or sanctum, threatened or involved CRM, low rectal tumor less than 5 centimeter from anal verge, where sphincter preservation attempt is being done, lateral pelvic node involvement, definitely radiation has to be offered. And if there is extramural venous invasion positivity or MRI. There are relative indications like if suppose there is a CT3 mid or upper rectal tumor with high risk features like extramural venous invasion, N2 or mucinous histology. There is N1, N2 positive disease without other high risk features. C3 lower rectum, even if there is no CRM threat, even in those cases, radiation has to be offered. If you are trying for sphincter preservation and if you want wait and watch strategy. When to give adjuvant radiation? Adjuvant radiation means patient has underwent surgery and should we give radiation now or not? So if there is pathologic stage T2, 3 with high risk features, say there is CRM positivity, T3, T4 or N plus, and the quality of TME is poor, or there are involved margins, or there is unexpected adverse pathology, for example, extensive nodal disease, then you have to give adjuvant radiation also. But for patients who have received, if the patient has received pre-op CTRT, or they have received total neoadjuvant treatment and have an R0 TME, and then you don't need adjuvant radiation. And post-op CTRT is usually long course in such cases with concurrent 5FU. So this is the indication for adjuvant radiation. Now, which patients can radiation be safely omitted? So this has come from evidence has come from 4-back trial, Mercury 2 trial, Prospect trials. So if it's a stage 1, T1, T2, standard of care is TME alone. There is no benefit from radiation. If it's a prospect trial criteria like CT2N1 or T3N0N1 mid or upper rectum, patient has received 6 cycles of FOLFOX. So you offer radiation only if there is less than 20% tumor regression. If it's a low surgical risk, or it means that the surgery has been done by a surgeon who has been doing TME routinely and MRI showed CRM was clear, then omission is justified even if T3C, if CRM is not threatened. Then T3AB, N0, MRI, clear CRM. If it's a mid or upper rectal tumor more than 10 centimeter, CRM is more than 2 millimeter, no extramural venous invasion, no node positive, surgery alone is acceptable as per the Mercury data. If the tumor is above 12 centimeter, then the tumor behaves like sigmoid, so no role of radiation. If there is a patient has a severe bowel or bladder dysfunction, patient has received prior pelvic RT, then you may omit radiation with close surveillance. But of course, these patients need a multidisciplinary team. Now, coming to advantages and disadvantages of TNT. There are multiple trials. I can't go into details of all of these, but you can see Stellar trial, Polish 2 trial, Rapido trial, Prodigy 23, CAO and Oprah trials. So if you see Stellar, Polish, and Rapido, the upper 3 trials, they have compared short course radiation with either Capox or Folfox, and they have compared it with long course CTRT. While Prodige 3 has taken induction FOLFIRINOX 6 cycles with long course RT and compared it with long course. Arrow trial induction FOLFOX with 3 cycles and long course RT. And Oprah also induction FOLFOX or Capox and then long course RT compared it with long course. So in all these trials, what we notice is that the pathological complete response was definitely higher with the TNT approach to the tune of 16 to 25% versus 5 to 11%. The 3-year disease-free survival was also approximately 5% better in all these trials. And local regional recurrence failure was also roughly around 5% better. In Oprah trial, they tried to omit radiation at all, and this found that 5-year TME-free survival was 39% if TNT was not done versus 54% if TNT was offered. So Prodigy 23 is basically for a very high-risk group. Oprah is basically for patients where you want to go for wait and watch policy. Rapido is for a short course radiation. So these are the trials just to make you remember. So when to assess the response after TNT? This slide is from courtesy of Dr. Kanika. So here different protocols have been used, and the assessment was done after 4 to 20 weeks. So what we found was that even if you do a wait and watch approach, around 15 to 34% patients, they have a regrowth. So please listen again. Patients, if they go for a wait and watch approach, then 15 to 34% patients, with approximately 1/3 patients will have a tumor regrowth. And the distant metastasis, in spite of giving a good amount of chemotherapy, the distant metastasis rate is 4 to 21%. And please look into this column, that is the salvage surgery. So around 80 to 100% of the patients eventually need salvage surgery. So when you counsel your patients for wait and watch approach, please discuss these results with your patients. And the 3-year survival rate is to the tune of 88 to 90%. So you can delay surgery, but I don't think that surgery would be completely avoidable. And if you are going for wait and watch strategy, then patients should have a 3-monthly MRI and endoscopy. So this is a decision tree. So if it's a stage 2-3 rectal cancer, T3, T4 disease or N positive, just see whether what is the risk of systemic risk. Does the patient has EMVI, N2 or multiple lateral nodes? If these high-risk features are present, then patients straight away goes for Prodigy 23 means FOLFIRINOX and long chemotherapy. If these are not there, then you see where is the tumor located. Is it above peritoneal reflection means it's a high rectal cancer? No nodes, then go for upfront surgery. If nodes are positive, then you can go for induction approach, that is a prospect trial, give FOLFOX. Sorry. And if the patient is below peritoneal reflection, that is a mid or low rectal cancer, then if you are thinking of doing low anterior resection, then give it's a low systemic risk, more than 2 millimeter margin, then FOLFOX can be done. And if CRM is less than 2 millimeter, then give long course RT and then FOLFOX or Oprah. But if it's if APR or ICR or VLR surgery is attempted, there is a low systemic risk, then and preferred approach is NOM. So now coming to long course RT and short course RT. So short course RT specifically means giving 25 gray in 5 fractions. You give the whole, you treat the pelvis, it means you treat the nodes also. Earlier, surgery was mandatory within 1 week, but now with a total new adjuvant approach, as in Rapido, then surgery can be delayed by 8 to 12 weeks. Advantages are that it's convenient, low acute toxicity, cost effective, but limitations are there is less downstaging if early surgery is done because there is no concurrent sensitization, and late toxicity is 10%. So it is best for resectable cases where there is no CRM threat. So long course CRT 45 to 50.4 gray surgery is done best in between 8 to 12 weeks after RT. Advantages are it leads to significant downstaging in 50% of the patients. There is high pathological complete response rate to the tune of 15 to 20%. The toxicity is 10 to 24% acute, and late toxicity is less than 10%. It is best if CRM is threatened, if you are aiming for sphincter preservation or organ preservation. Now, note the BD. In short course, the total EQD2 is 33 gray, while in long course it is 45 to 50 gray. In total neoadjuvant approach, then if you can give short course RT as well as long course RT. Long course RT, highest pathological complete response to the tune of 28 to 30%. Best for high risk cases, MRF is positive, EMVI positive, and where you want to go for organ preservation techniques. And some patients may be a candidate for contact brachytherapy. I'm not going into that. So I've talked about the advantages and disadvantages of short course and long course. Now, if we see the results, so these are the short course RT trials. And if you see the local recurrence rate in all these trials is roughly around 10%. If we see the long course RT trials, I think the results are absolutely a mirror image. In this also, you see the local recurrence risk is 10%, distant meds is 30%, and overall survival is 70%. So that's why maybe the approach, the concept of total neoadjuvant came in, because we were not able to improve these results even after changing from short course to long course. Now, can we increase the PAT-CR rates with short course RT? So if you do short course RT and you do immediate surgery, then the PAT-CR rates are only 1.4%. But if you do short course and do a delayed surgery, then PAT-CR rates are 11.8%. But if you do long course RT, then the PAT-CR rates, they are around 15 to 20%. In the Korean trial, they said that if you delay surgery by 6 to 7 weeks, then the CR rates improved by 10% and they peaked at 9 to 10 weeks. But if you delayed by more than 11 weeks, then the fibrosis risk was more. So surgery should preferably be done within 10 weeks of radiation. After pre-op long course RT, the PAT-CR rates are around 15 to 20%. But if we do TNT, so you can see with Rapido, the PAT-CR rates are 28.4%. With Stellar, they are 21.8%. And with Prodige or Rapido, they are 28%. And with these approaches, the non-operative management or wait and watch policy may be possible in some of the patients. So what is the optimal time to select chemo and surgery? So as I told you that downstaging more if after short course, the interval for surgery is more than 1 week, because toxicity is more if the surgery is done within a week. After long course, the sphincter preservation is same between 7 and 11 weeks, but there is high morbidity if interval is more than 11 weeks. So now coming to contouring guidelines, I think this is a mixed audience, so I'm not going into details, but GTV, you have to see the macroscopic tumor visible on MRI, CT, look for the colonoscopy and sigmoidoscopy findings. And superior border is superior mesorectal fascia is 1 to 2 centimeter above the tumor. Inferior border is anal verge or 1 centimeter below tumor. Then CTV is you give GTV plus 2 to 3 centimeter longitudinal margins. Mesorectum has to be included. Entire mesorectal compartment within the mesorectal fascia has to be included. The presacral, perirectal, internal iliac nodes have to be included. But if lateral nodes are positive, then obturator has to be included. And external iliac nodes have to be added if the T4 tumor invading anterior structures is there. PTV is 0.5 to 1 centimeter, depending on the technique you are using. If you are doing daily CBCT, then it can be 0.5 centimeter. So these are the sites where there is maximum chance of recurrence: the presacral nodes, the mesorectum, the lateral lymph nodes, external iliac nodes, istiorectal fossa, sphincter complex, and inguinal nodes. So please look for a contours again and again after contouring these areas. And for the lateral pelvic lymph nodes, you have to see the guidelines to understand how to include them. These are the dose OAR dose constraints for I've put them separately for long course as well as short course. Then radiation toxicity, acute effects that is occurring within 3 months, diarrhea, proctitis, tenesmus, rectal bleeding, grade 3 to 4 in 10 to 15% with CRT. There can be dysuria, frequency, cystitis. It's more common with anterior tumors, can be managed with alpha blockers, urine culture, or hydration. There can be moist desquamations, use barrier creams, Mepilex foam, or wound care. Then neutropenia, thrombocytopenia, and if patients have received chemo before, then these chances are very high. So you may include growth factor support on Saturday and Sunday. Then fatigue, nausea, and if patients are on capecitabine, they may have hand-foot syndrome. Late effects, there can be anterior resection syndrome, that is fecal incontinence, urgency, or chronic diarrhea. There is a large score to note that. Then there can be bladder fibrosis, urgent incontinence, sexual dysfunction. So vaginal dilators can be advised to these patients. There can be pelvic insufficiency, fractures, femoral head AVNs can also happen. So you should do DEXA scan and bisphosphonates post-treatment. Lower limb lymphedema, so compression stockings and physiotherapy should be advised to every patient. And please note that there is 1.4 times increased risk of pelvic second primary, say bladder, prostate, and uterus at 10 plus years. So annual surveillance and patient counseling is also very, very important. So just to conclude, you have to discuss every case in MDT. The MRI has to be discussed with the radiologist for each and every patient. Go and personally discuss with the radiologist. If it's a CT1, T2, N0 stage 1, then you do surgery. If it's a CT3, N0, N1 mid or upper rectum, then you can give selective RT or Folfox alone as per prospect trial. If it's a T3-4 MRF positive or CT4N2 with extramural venous invasion, neoadjuvant RT or TNT is preferred, and you can go for Rapido or OPRA protocol. And in this group, RT should be omitted if there was a clear CRM and surgery was done by a good doctor. Response assessment, MRI at 8 to 12 weeks post RT. So it means there should be no residual tumor and no nodal disease. Wait and watch strategy only if complete a clinical response and after TNT. MRI plus endoscopy plus CEA should be done every 3 months. And as I said, 30% patients may have a regrowth. So close follow-up is very much mandatory. So my key takeaways are that MRI is mandatory to see for CRM, EMVI, height and nodal status. Stage 1, CT1, T2, N0, no RT, high quality TME alone is sufficient. As per prospect trial, RT can be omitted and selected. CT3 mid upper rectum for patients who have received Folfox. TNT Rapido Opera is the new standard for high risk disease because it leads to high pathologically complete response rate. For very high risk patients, FOLFIRINOX with Prodige is a better protocol. For organ preservation, wait and watch. It's reserved for complete patients who have a complete response, and strict surveillance is essential. VMAT plus IGRT in daily CBCT is very, very important, and late toxicity is real. So large sexual dysfunction, pelvic fractures, so Kegel exercises, and you can also mark the sphincter and see the doses received by the sphincter to prevent the chances of stool leakage post-treatment. So I think the shortage of time, I would like to stop here and I would be open to any questions.
Thank you so much,
Hello.
ma'am. It's such a vast topic. Still, you covered. Thank you, ma'am. Thank you so much. It's such a vast topic, and still you covered this in such a short time in a simplified and.
You're not audible. Can you be a bit louder, please?
Thank you, ma'am. It's a very vast topic. Still, in such a short time, you have simplified and clearly explained the practical aspects and principles of radiotherapy supported by the evidence.
Thank you so much.
Any questions from the audience? If there are no questions, we'll move on to the next session, panel
Sure.
discussion on the TNT.
Okay, thank you, ma'am, for that insightful presentation. So we now move on to our first panel discussion. I invite Dr. K. Meena, consultant medical oncologist, AIG Hospitals, Hyderabad, to moderate this session. Our esteemed panelist, Dr. Chaitanya, Senior Consultant and Director, Department of Radiology, AIG Banjara Hills, Hyderabad, Dr. Ravi Krishna, Senior Consultant, Lead Medical and Hemato-Oncologist, and Bone Marrow and Cellular Therapy Physician at Medicover Hospital, Hyderabad, Dr. Kanu Charan Patra, Clinical Director and HOD, Radiation Oncologist at Mahatma Gandhi Cancer Hospital and Research Institute, Visakhapatnam, Dr. Prithvi, Senior Consultant, GI Oncologist and Advanced Laparoscopic and Robotic Surgeon at Medicover Hospital, Hyderabad. Now, I would like to hand over to the moderator, Dr. K. Meena. Ma'am, over to you.
Thank you for that wonderful introduction, and very good evening to one and all. Thank you, IAIO, for this opportunity, and Dr. Rindu, amazing work. I mean, rectal cancer is so vast, and you covered everything from anatomy to all the treatment indications, which made my job much, much easier. So without further ado, I would like to share my slides and get into the case scenarios. Is my screen visible?
Yes, ma'am. Visible.
Yes, great. So these cases are from our treating center, and the slides that I have used to refer the trials have been borrowed from ESMO Academy. So moving on, not much introduction is required. The stage is set. So let's move directly to the cases. The first case is a 63-year-old lady who came with complaints of incomplete bowel evacuation, flatulence, and belching. Clinically, no major findings were noted. She had prior surgeries, appendectomy, and colonic polypectomy 12 years prior. She has a family history of attenuated FAP. Upper GI scopy was suggestive of diminutive polyps, and colonoscopy showed a semicircumferential friable vascular polypoidal growth, 20 centimeter from the anal verge, with multiple sessile polyps, the largest one being 1.5 centimeters. Histopathology of the polypoidal growth is a well-differentiated adenocarcinoma. Serum CEA is 10 nanogram per ml. So these are the MRI images of this patient. Dr. Chaitanya, can you please tell me the findings of this case?
Yeah, good evening, everyone. This case, MRI slides show these are axial oblique sections showing circumferential T2 intermediate signal intensity, irregular transmural wall thickening involving the rectosigmoid junction and the high rectum. Apart from that, we are also seeing two irregular spiculated lesions away from the lesion, suggestive of tumor deposits. And in this section, we are seeing extramural vascular invasion seen as linear, irregular, serpiginous signal intensity tumor extending along the vein. Apart from these two lesions, we are also seeing, there is a hypointense deposit on the right ovary, and there is no involvement of MRF, and APR is not applicable.
Not.
Yeah, not involved. Yeah, and no, I think not included in this is few mesorectal lymph nodes are also involved. So altogether, this comes under T3 CD, EMVI positive, tumor deposit positive, and metastasis on the right ovary. So T3
Metastasis.
CD N plus M plus. Yeah.
M1. So, Dr. Chaitanya, one question is, how do you define the upper limit of rectum on MRI? Would you consider a sigmoid takeoff or sacral promontory line or the anterior peritoneal reflection?
So, according to the recent guidelines, sigmoid takeoff is more reliable than the sacral promontory. So, sigmoid takeoff defines the rectosigmoid junction where sigmoid colon diverges from the rectum either in axial view or sagittal view. It marks
Or
the transition. It marks the transition from the fixed mesorectum to the mobile mesocolon.
Okay. So are we still going by the conventional classification of 5 centimeter upper, mid, lower, 5 centimeter each, or has that changed?
Yes. The distance from the anorectal junction, if the tumor is less than 5 centimeters from the anorectal junction, it is called as lower rectal tumor. And if it is above 5 centimeters from the anorectal junction, it is called as high rectal tumor.
So it is no longer the upper, mid, lower, is it?
Yes, yes.
All right. So how do we identify the anterior peritoneal reflection? I mean, demarcate whether it is intraperitoneal or extraperitoneal disease.
Yeah, anterior peritoneal reflection is again an important landmark in the rectal anatomy. It differentiates the intraperitoneal and extraperitoneal rectum. It is seen as a hypointense line just above the seminal vesicles in case of males, whereas it is seen at the level of uterocervical junction in case of females.
In case of females. So going to Dr. Prithvi,
Hello.
from a surgical standpoint, what is the radiological landmark you would consider to differentiate sigmoid from upper rectal tumors?
Yeah, so as clearly told by Dr. Chaitanya, we are considering sigmoid takeoff as a radiological landmark, but it might not be seen as alone as done by radiologists because we go and operate. I need to know the exact extension of whether it is a colonic tumor or a rectal tumor. This is where the confusion comes in the rectosigmoid tumors, how to treat them as colonic tumors or rectal tumors. So you should also take into consideration of the anterior peritoneal reflection and the sigmoid takeoff, because depending on it, our surgery will change. So not one factor alone, 2, 3 factors by correlating with the intraoperative knowledge which we gain over a few years.
All right. How would the management vary if many of the lesions, they may not clearly be commented as sigmoid or rectum? Sometimes it is reported as rectosigmoid. So in such a case, would this differentiation alter your treatment? Would management vary?
So in good places, when we have good radiologists and all, it is very good that they give us the details that it is a rectal or sigmoid. But most of the radiologists in the private practice, which we are in, usually just give rectosigmoid area. So definitely we sit with the radiologist, we discuss it with the radiologist. Although in this particular case, the tumor is clear in the sigmoid colon, I mean above peritoneal reflection. But still you can see the enlarged mesorectal lymph nodes below the peritoneal reflection. So that means there is some extension below the peritoneal reflection internally, which is causing these mesorectal lymph nodes to be involved. Otherwise, there would be no reason why the mesorectal lymph nodes should be involved. So in such cases, when we see that mesorectal lymph nodes are involved and the tumor is still high, then we probably will consider them as a bad tumor, as upper rectal tumor, and treat accordingly. If we don't find any mesorectal lymph nodes and other bad features, then we consider it as sigmoid colon tumor and we operate upfront.
Okay. So would the tumor relation to the anterior peritoneal reflection influence your management?
Yeah, definitely. Anteperitoneal reflection, sigmoid takeoff, and the presence of absence of mesorectal lymph nodes below the lesion.
Okay. For high rectal tumors, which are like 10 to 15 centimeters with clear CRM and favorable features on MRI, would RT be considered? I mean, upfront operable.
Yeah. So if there is MRF is negative, there are no nodes and there is no EMY, no tumor deposits and all, definitely an upfront surgery can be offered to the patient, considering that one of the treatment can be omitted, like radiation can be altogether omitted, and we'll get a proper staging to give actual chemotherapy indication. And accordingly, we might treat the patient by offering less treatment. So de-intensification is the norm as such. But in this case, I mean, in the case which is given, there are mesorectal lymph nodes. So I think we would like to go ahead with the neoadjuvant therapy and then only operate this kind of patient. But at the same time, I'll discuss with the radiation oncologist as how much the upper portal will be and how much will the risk be to the small bowel, how much will be the chances of radiation enteritis and how much fistulation chances, how will that impact the patient? So it is not just that I go and remove the tumor and hand out the patient to medical oncologist or radiation oncologist hands out to me. It is a combined discussion in the primary interest of patient.
Of course. Does the sigmoid takeoff influence the choice between your surgical approach? I mean, will it influence whether it can be anterior resection versus total mesorectal excision?
Yeah. So as I said again, I mean, if the tumor is completely above anterior peritoneal reflection, there are no lymph nodes, and the tumor is touching the anterior peritoneal reflection or just above the anterior peritoneal reflection. For the sake of distal resection, which are the invisible tumor cells or invisible nodes, we might just do a partial mesorectal excision when it is in the rectal sigmoid area, which is 5 centimeters, and then we can anastomose still upfront without a protective stoma. But if it is crossing below, then we might have to go for TME to reduce the local recurrence rates, which actually after healed surgery.
All right. So in borderline rectosigmoid tumors, would radiology-driven decisions suffice to avoid neoadjuvant therapy? Or would you prefer to treat it as a rectal cancer to avoid local recurrence risk?
I think a thorough discussion with the radiologist with regards to the exact location, exact sigmoid takeoff, and presence of these bad features, presence of mesorectal lymph nodes below the lesion, all these things will definitely be required for us to take a decision.
All right. Thank you, Dr. Prithvi. Dr. Charan, can you hear me?
Hello. Yes.
Yes. Dr. Charan, the radiotherapy indication for tumor position, would you consider peritoneal reflection, sigmoid takeoff, or anal verge?
I will take sigmoid takeoff mostly. And if it is a bulk of the tumor is in the sigmoid and in the floating part, so I will prefer not prefer radiotherapy. But if the bulk of the tumor is in the rectum and not in the much part is not in the floating part of the sigmoid, I can go for the radiation.
Okay. So, like the next question answers what you have already told. That if it is near sigmoid takeoff, it can be considered colon-like and RT can be omitted. So, Dr. Charan, how to integrate the tumor height, the low or high, with the MRI risk features when deciding between no RT, short course RT, or long course RT?
Okay, so I am if you see the Rapido trial in the long outcome, there is a local recurrence is more within short course RTs. So I am not in the favor in the person giving the short course RT and completing the radiation as soon as possible. So I am always preferring the long course RT, and most of the lower anal canal anorectal tumors we should go for long course RT. And if you see the Rapido trial recent data, so chance local recurrence is high.
And tumor location, does it influence the radiotherapy target volumes, the inclusion of mesorectum, presacral space, and the lateral pelvic nodes?
So if you want to treat the rectosigmoids, all rectal stages, these are the mandatory things you have to take. There is no, there is not optional things. Mesorectum has to be treated, perisacral nodes. If there is involving of the ischiorectal fossa, you have to treat the proper, you have to include all those things. So there is no optional thing. All should be taken in proper way.
All should be taken. And even if the imaging is not suggesting any nodal involvement, I mean lateral pelvic node, if there is no suspicion, even then would it be considered in the radiation field?
So usually the 3 points here, we usually don't include even anal canal involved. We don't include external inguinal nodes or external iliac nodes. One thing. Second thing, we usually treat perisacral obturator and internal iliac, not external iliac. But there is a third point: if there is a involvement of anterior structures like prostate, bladder, seminal vesicles, and cervix, uterus, then we have to include the external iliac. Fourth thing, if there is internal iliac, then we include external iliac. Otherwise, no.
Otherwise, not included. Thank you. So this patient, when they underwent the whole body PET CT, it was showing the lesion in the proximal rectum with contiguous involvement of peritoneal reflection as well as peritoneal nodules in pouch of Douglas. And so the patient was started on palliative therapy and the family was counseled for genetic testing and regular screening. Dr. Prithvi, one small doubt: in such cases of attenuated FAP, would you consider palliative or prophylactic removal of the colon, prophylactic colectomy, or would you consider the number of polyps or any other factors before you make such decision?
Uh, why was this made palliative? I just missed something, I think.
No, no. The
Discrete-
patient had also had discrete peritoneal nodules in the pouch of Douglas with adjacent mesenteric nodules also. And because it was locally advanced, and there was also a suspicious lesion in the ovary.
Yeah.
So that is why this became palliative.
Fantastic.
The intent became palliative.
Yeah. So with the current with the current evolution of the drugs and all the radiation techniques and the surgical techniques, I think upfront decision of intent on the treatment patient is actually not valid anymore, because most of them sometimes turn back, except for these few peritoneal nodules. We have operated many cases which we have deemed palliative initially. After exenteration, they have completely recovered and they were alive after 6 years and all. So upfront decision that we are making a palliative patient is not accepted anymore. It's a dynamic change of the intent. And with these peritoneal nodules on the pouch of Douglas, I would like to really see whether they are in continuity with the tumor. Like the peritoneal reflection is involved. If it is a serosal disease which is presenting like peritoneal nodules, then they should not be exactly taken as those distant peritoneal nodules, which will make it really a palliative. And the amount of peritoneal involvement, whether it is localized to the tumor or is it seen in the distant peritoneum, skipped peritoneum areas, these are the things which I might not get from the PET scan, but definitely as you have given chemo, or in such cases, if the patient is young, I forgot age of this patient. If the patient is so young, then
Hello. Dr. Prithvi? Dr. Prithvi, we're not able to hear you. Hello, is Dr. Prithvi not audible to the others too, or is it just me?
No, ma'am,
Yeah,
not
we are not
audible.
audible.
Not audible. Okay.
Yeah, so what I will take it from here, because we work together. So my only thing was like, even in such cases, we will do staging laparoscopy and then notify what is the PCI, and then we'll take a call. So rather than just directly going ahead and then labeling it as palliative. So
Agreed. But in this case where there is a suspicious ovarian involvement, would you still not want to consider it as palliative?
no, so that is what he's trying to say. So he just wanted to see like whether those things are in a continuity with the tumor, okay, rather than an isolated tumor deposit. Okay, so even that isolated tumor deposits are there, we need to classify it as like into PCI, like what is the PCI in staging laparoscopy, and then take a call whether we can really have to make it as a palliative or a curative. First give chemotherapy and then maybe reassess after 4 to 6 cycles and then take it. So that is what I think.
So there is one problem in this scenario, Dr. Charan. The problem is, if we label it as palliative, again, we have to do the mutational profiling and we have the chance to add another targeted therapy, which if it is curative, we do not add usually. So yes, I do agree that we have to do a diagnostic lab and then check if there is involvement and then go ahead. But if there is a problem there, then how do we label this case? Whether we add the cetuximab and consider it as palliative intent, or still label it as curative and go only with the chemo? Hello?
am I audible now, Dr. Meena?
Yes, you are audible now.
Oh, sorry. I think a problem with my internet connection.
There was some signal issue. Yes, but you are audible now, Dr. Prithvi.
Yeah. So the peritoneal disease, what I was saying is we would like to have a diagnostic laparoscopy to see whether it is a continuity disease, and the ovarian deposit, how big is the deposit, how extent of the peritoneum is involved. All this will come into picture before we decide the intent of the treatment and proceed with the further thing. And the other thing is, when there is actually an ovarian deposit, depending on the size, the response to the chemotherapy will also be not good, as proven in few papers. And we have seen few patients clinically also, that in the presence of ovarian mets from colorectal tumors, the response of chemotherapy will not be as good as when you have removed those things. So in few cases, we remove the ovarian mets and actually give chemotherapy to give it better response, and then reassess at later point of time when we can actually salvage them completely, because few of the patients and with the ongoing techniques, many patients could be salvaged. If there is a limited peritoneal disease also, we can offer them radical intent treatments.
That is interesting. Something to think about the next time we have such a patient. So thank you all for your inputs on that case. So moving on to the next case. This is a 50-year-old male with no comorbidities who had difficulty in defecation of 10 months duration with pain, bleeding per rectum, tenesmus, incomplete evacuation, altered bowel habits, loss of appetite, and loss of weight. Colonoscopy was suggestive of a large polypoidal lesion in proximal rectum extending throughout the length of the rectum. Histopathology is a moderately differentiated adenocarcinoma, and serum CEA is 21.6 nanogram per ml. Dr. Chaitanya, can you please let us know what are the MRI findings that are significant and what we should watch for?
Yes, please. There is a large irregular polypoidal lesion involving the entire rectal lumen with a broad-based hypointense stalk attached in the posterior wall of proximal rectum. Inferiorly, it is extending up to the distal rectum, but not extending into the anal canal. And here there is extramural spread is seen for a distance of 9 mm, making it a T3CD disease. And MRF is involved by the abnormal enlarged mesorectal lymph node, which is clearly measuring more than 10 mm in the short axis diameter at 3 o'clock position. In the same case, there is also an involved lymph node at 6 o'clock position, which is showing diffusion restriction. Interestingly, in this diffusion, we can see the EMVI, the hyperintense signal on diffusion. It is representing the EMVI. So it makes a T3CD and N plus disease with MRF positive.
With MRF positivity.
Yes.
All right. So in this case, there was a suspicious 4 millimeter node in obturator node that was reported. So one small doubt, how do we know if a node is involved or reactive? What are the findings that we look for in such cases?
Yes. Criteria for the lateral group of lymph nodes, that is obturator or internal iliac, size-wise, it is more than 7 mm along the short axis diameter. If it is 5 to 7 mm, apart from the size, we also take other malignant features like indistinct margins, heterogeneous signal intensity, or rounded margins, rounded shape. So, but apart from these criteria, even if the lymph node is 4 mm or 3 mm, if it shows mucin signal intensities, we consider it as positive disease or lymph
positive disease. Yes. Dr. Ravi, which to prioritize? Induction chemotherapy to address the potential micrometastatic disease or consolidation chemotherapy after radiation to maximize the window for tumor downstaging? What would be your choice first?
Yeah, so it all depends on, like, as you rightly mentioned, so what we are going to address. So are we going to address the potential micrometastatic disease or the threatened CRM or MRF positive, which is the major risk factor for the local recurrence? So in this particular case, I would, the threatened CRM or the MRF positive is the higher risk factor, which is of a more concern for me. So I would go for the upfront NSCT-RT and then followed by the consolidation. But induction in this case, even that EMVI is high, there is a slightly elevated CEA, which indicates slight potential for the micrometastatic. But for me, the major factor here is the MRF positive. So I would proceed for the CT-RT.
And what are the cases where you would want to consider chemo first then?
To be frank with you, very minimal cases, like as you mentioned previously, that deposits on the ovary, such kind of cases, or significantly EMVI positive, very highly elevated CEA, and without any threatened CRM, those are the kind of cases. But I'm not convinced with the, to be frank with you, the induction first kind of therapy. So I'm more comfortable with the CT-RT first and then send for the assessment. Multiple reasons for that one. So though the PRODIGE trial says that there is an overall survival benefit, but we have to take it with a pinch of salt because there are a lot of things we need to be of very critical when we analyze that study.
Okay. Dr. Prithvi, if the patient achieves good response after TNT, what is your threshold for attempting a sphincter preserving low anterior resection versus a definitive abdominoperineal resection?
Yeah, just before going to answer this question, I would like to take a two-step back, coming with the lateral node and the TNT. So the lateral, if it is just 7 mm before the, in the retreatment, restaging MRI, then it is significant. But after in the in the prior MRI, before treatment. And after treatment, there are two different distinct measurements which we take. There is internal iliac group, obturator group. Internal iliac group, which is actually an indicator for the locally aggressive disease, whereas the obturator group is the sign that this could be a high potential case for the distant mets, similar to external oblique, external iliac. This difference comes between the Eastern and Western philosophy, but Eastern philosophy has won because most of the Westerners have taken it just to give some chemotherapy or radiation, and Easterners have come with the lateral lymph node dissection. This is one point I would like to make. And with regards to the chemotherapy, whether it should be induction chemotherapy, consultation chemotherapy, because we cannot just take the trials at face value and we have to critically evaluate them, which has already been done. We have only 2 trials which have got overall survival in TNT trials, which were not the prefixed analysis. I mean, those were not the planned analysis. If you look at Produce 23 or the Stella trial, and there have been huge criticisms among them. So when we see that there is a EMVI grade of 4, and there are a good number of obturator nodes or some external iliac node, which is surely metastatic, that means when there is chances that this could turn metastatic during the course of treatment, then probably I would request my medical oncologist to think about induction chemotherapy. Their
Chemo
decision
first.
in those
Personally,
conditions.
as a medical oncologist myself, I would have considered chemo first for this case. Because
But
the
not
chances of systemic spread are high with the EMVI involvement and the obturator node involvement.
but I would
It
need
is
to know the
all of these
grade of
cases
EMVI.
are multidisciplinary, and it's like a coordinated choreography between the surgeon, radiation oncologist, and surgical oncologist.
Yeah,
So
but I
I
think
would
we should be very
differ.
critical in the induction chemotherapy, as Ravi said. I need
Yeah.
to know the exact grade of EMVI. I have to look it in 3 different planes of the EMVI, confirm that it is EMVI, it's not a node, and how big are the nodes, how many number of the mesorectal lymph nodes, how many number of the obturator nodes are involved, whether the size of the obturator nodes, and the MMR presence, I mean MSI high or MSI low, whether they're going to respond to chemo or not. These all factors play before we directly give induction. We cannot just take Produce 23, induction chemo, we'll give it and treat. It is an individualized decision based on the MDR discussion. These cases are the ones which actually required an extensive tumor board discussions actually.
yes. And now regarding the surgical option?
So it depends on actually what profession the patient is, how is his continence rate, and what is his expectation from the treatment that makes the decision. Because virtually we have done ultra low anterior resections on patients who have 1 to 2 centimeters from the anal verge, patients who have got Lars syndromes and who have turned into completely major Lars and completely became dependent on the stoma. Those, although we have continued the integrity of the sphincters, it was of no use. So I would like to discuss with the patient what actually he's expecting and what can be done. Technically, if I can do a ISR, if I can spare the sphincter, it doesn't mean that I should go and do it. It depends on the patient choice, patient response, how is the Lars prediction scores, and what are the neoadjuvant therapies we are going to give, short course or long course. These all define whether we go for an APR or LAR. If a patient is not very much considerate about the stigma of the society, which is having an end stoma, in some patients, actually in Indian settings, end stoma will do much better quality of life for a patient who is actually working, who wants to work after the treatment.
Noted. And if there is this lateral pelvic node involvement, would you consider the Japanese style of management and go for the extended dissection, or would you prefer it being addressed in the radiation?
I think, Ravi, you have something to say?
Yeah. So I just wanted so for example, in this case, if at all we have to proceed for the induction chemotherapy, I just wanted to understand what is the goal of the induction. So why we wanted to give induction first? Is it to reduce the distance metastasis or improve the overall survival? So those are the things which I will look into. So if my goal is to prevent the distance metastasis or the overall survival, then I have two points to raise actually. See, in the Prodigy, even if you take that overall survival benefit, whatever that 7% benefit at 7-year timeline, okay, so that is not a significant one. So the problem was, if you see the initial analysis in the control arm, in the initial post-operative 60 day, there are almost like 6 deaths which are not related to the malignancy. So they are mainly because of the like
Unrelated
one
things.
case was attributed to the suicide, one case was for the comorbidities. So and if you see after that, so there is no difference between the two survival curves. So almost the survival curves runs parallel to each other. Okay, so we cannot say that because there is an overall survival, we wanted to give induction for. Second point, if at all we wanted to improve the distance metastasis-free survival, there are significant data saying that improving the distance metastasis-free survival, but not having any impact on the overall survival. So what it has shown was the chemotherapy has reduced the majority of the liver mets only. Okay, and rest of the mets there is no difference. And liver mets are, as rightly like we can see, there are majority of the liver mets are salvageable even in the control arm. So these are the two things which we should keep in mind. So these are not the points which are in favor of the induction chemotherapy. So that is the reason for me, the CRM or like the MRF positive, which is an important factor for the local recurrence, is the one which is important. That's why I prefer NACTRT first rather than induction.
Yeah,
Noted.
completely agree with you. Unless until there are signs that this can go metastatic, no induction chemotherapy, straightforward radiation, assess the response, and then decide whether you have to give some consultation or to go ahead with surgery. No Produce 23 direct application just because the tumor characteristics say so that on the broad line there is an EMVA that EMVA 1-2 grade doesn't actually require induction chemo. EMVA grade 3-4 or the response of the EMVA which is not reducing post radiation, that is a sign which is indicative that it might be metastatic. So it is all dynamic response. And definitely I would agree with you that induction chemotherapy should not be the goal for all cases because that is not going to give any results. Actually, evidence has not shown. And with regards to the lateral, sorry?
Yes, with regards to the lymph node dissection.
Yeah, with regards to lymph node dissection, I think we have started following this Eastern thing for the last 6-7 years. I think since 2018. Tata Memorial Hospital, where I have worked extensively in the colorectal department for almost 2.5 to 3 years. We have started this lateral pelvic lymph node dissection because it is the only thing which has reduced recurrences depending on the size criteria. Because unlike the mesorectal lymph nodes, for the lateral nodes, you don't have morphological criteria. It is only size criteria which has reduced the recurrence. You can see that lateral node consortium, which has shown that after the reduction of the size and doing lateral lymph node dissection, 50% of the local recurrences can be reduced. So if the size of internal iliac is above 4 mm and as an obturator node above 6 mm after the neoadjuvant therapy, then I would definitely like to go ahead with lateral lymph node dissection because until now the evidence has shown that has reduced local recurrence and it is no more a metastatic disease like the external iliac nodes.
Okay, Dr. Sharan, considering the bulkiness of the tumor and the lateral node involvement, would you consider long course chemoradiation or overshot? Dr. Sharan?
Yes, ma'am. Hello.
Which would be your choice of radiation, doctor? Would it be long course chemoradiation or short course?
Madam, long course only.
Long course. And yes, Dr. Prithvi was more intent on operating the lateral nodes rather than addressing them with surgery. But in case they come to you, would you go for an integrated boost?
Simultaneous integrated boost is not to the node or a primary you are asking, madam?
To the involved mesorectal deposits and the obturator nodes, sir.
So we are going, see, if you are going long course chemoradiation, you are going for the 45 grade, 25 fraction, all mesorectum and one elective nodes, everything. Another 5.4 grade in 3 fraction, we are going to the gross nodes and a gross tumor and mesorectum. So you can do the simultaneous, some people prefer simultaneous integrated boost SIB 45, 25 and 15, 25. But you can go for those sequential also 45, 25 and 5.4 into 3. The both are okay, no problem. If you go also SIV is not an issue.
Okay. Dr. Prithvi, if the restaging MRI shows a complete clinical response with the disappearance of EMVI and node normalization, is it okay to wait and watch as per OPRA, or would you, considering the initial high risk status of the disease, would you want to go ahead with surgery?
I would discuss options for the patient, but I'm not actually in favor of for this patient because of the EMVA and those nodes. The chance of regrowths are very high, and our population being even in a high socioeconomic status, the compliance being very low, and the 3-monthly follow-up, which is not actually standardized and protocolized, I would like to go ahead with surgery until unless patient puts an obligation that she wants to check that thing, which is not a bad option. But because being a bulky patient, bulky tumor, huge size tumor, and the upper extent of the tumor not being palpable, I have missed the exact length of the tumor. If the tumor is not in the reach of my finger and a bulky tumor, bad EMVI, response of the EMVI is not good. Although the primary tumor would have reduced, the EMVI has not responded, then I would definitely not go for watch and wait.
Okay, noted. So I will just run through this. Enough has been discussed about the trials per se, and the benefit of short course, long course, the caveats of Prodigy also have been discussed. Is there time for me to discuss another case or two? Or am I running behind? Hello?
Actually, hello. You can go ahead with case 3, ma'am. Actually, moderator for the next session is yet to join.
All right. Then moving on. So prospect is, yes, as Dr. Ravi has told, Prodigy is one study where they have given 6 cycles of FOLFIRINOX followed by chemoradiation and surgery. He has already talked about the advantages and caveats of the study. Prospect is an American trial, which is a non-inferiority trial, which has tested FOLFOX. In the TNT, so far Prodigy has only showed FOLFIRINOX, but Prospect tested FOLFOX. One caveat of this study is this has included early stages also. Nearly 35% of the patients are of initial operable stages. So that is one caveat, but this study has shown that it is a non-inferiority and non-inferiority is seen. And this is OPERA, another trial where there is a boost with radiation if for organ preservation. And this study has shown that there is some organ preservation, but there is also higher side effect profile. Now going to the third case, which is a 43-year-old male who presented with bleeding per rectum. The colonoscopy showed a circumferential ulceraproliferative growth in the rectum, which is moderate to poorly differentiated adenocarcinoma. These are the MRI pictures. Dr. Chaitanya, can you please tell us the findings?
Yes, there is a near circumferential T2 intermediate signal intensity growth involving the lower rectum and extending into anal canal.
Okay, so
focally, this sorry, yeah, it is focally extending beyond the intersphincteric space and involving the deep fibers of external sphincter from 5 to 7 o'clock position. Yeah, thank you.
And so, these high risk features, madam?
Yeah, there is a right obturator lymph node which is definitely measuring 8.2 mm in short axis diameter, and even the signal intense shape is round and signal intensity is heterogeneous and hyper intense. So,
and MRF?
MRF is positive in this case.
Okay.
Sorry, in this cut we are seeing MRF. So total staging will be T4B N plus anal plus.
Okay. So Dr. Prithvi, so there is external sphincter invasion, MRF. Should we approach this as a curative radical surgery primary goal, or we can go for an organ preservation after TNT?
I think having a T4B disease MRF positive, this is not a good patient for organ preservation. I think even the radiation oncologist would agree with me that this is not quite a good responder, which is going to be. I think I wanted to just give with a local radiation to reduce the future local recurrence after my surgery, and then go ahead with the APR, completely remove the disease. I would not be in favor of organ preservation for this kind of patients.
Noted. Dr. Ravi, I know you've made it amply clear, but what would be your TNT approach?
Yeah, like NACTRT first, considering MRF positive.
Okay. And Dr. Charan, in this radiologically positive right obturator note, should radiation boost be done?
Yes, madam.
Okay. Dr. Prithvi, if CRM remains threatened post-treatment, would you go for an extended resection?
Yeah, so we would like to go with the extra elevator APR, where we continuously take up all the tumors, because the anterior margin, which is the most problematic in APRs, and that has not reduced over time. So in that case, the discussion with the radiologist to see whether should we include the other organs so that we are not leaving any disease behind makes my decision. But definitely it is an extended resection if it is not responding well, because prior to surgery, what I'm worried is almost about the MRI negative predictive value. nothing about. The tumor might come in the post-op histopathologist saying it was not involved, but still, considering all this thing, we have to go ahead with extended resections.
And what is the threshold to call CRM clearance post such TNT treatment?
I didn't get this question actually.
I mean, normally your CRM 1 mm, what would be the threshold post-treatment?
It's the same criteria, even post-treatment, whether the MRF is involved, mesorectal fascia is involved or not. It is the same criteria. Surgically, we would be more on the over-treatment side in these cases, removing more organs rather than leaving some disease behind, in which case salvage is not going to be a possibility.
Salvage is not going to, and wait and watch is out of question in such a case.
Yeah.
One last case before we wind up. A 57-year-old female who presented in 2018 with bleeding per rectum and increased stool frequency of 3 months duration, loss of appetite and loss of weight. Colonoscopy was done, which showed a circumferential nodular growth in the rectum, causing luminal narrowing. It was a well to moderately differentiated adenocarcinoma. And endoscopic ultrasound and showed non-circumferential lesions starting 11 centimeter from the anal verge, extending beyond 15 centimeter, involving all rectal layers and infiltrating mesorectum with venous invasion. It was T3N0 with a serum CEA of 60. The patient, all this was done outside. The MRI pelvis was suggestive of bulky annular polypoidal eroding mass involving proximal rectum of length 6.3 centimeters, wall thickness 14 mm with mesorectal fat stranding, mesenteric edema, and enlarged mesorectal lymph nodes, largest measuring 9 mm in short axis. The CRM was clear. Extramural spread was noted with 3.2 into 3 centimeter polypoidal mass. Clinically, it was T3N1M0. At the time, the patient received 1 cycle of Kepox and chemoradiation of 50 gray in 25 fractions. And the draining lymph nodes also were addressed and concurrent capecitabine was given. The patient later underwent anterior resection with diversion ileostomy. Post-op, it was YPT2N0 with a Mandard regression grading grade 2, no LVI or PNI. The patient received 3 cycles of Kepox adjuvant and ileostomy closure was done. In 2022, the PET-CT showed a small intraluminal polypoidal lesion in the distal descending colon, which was tubulovillous adenoma with foci of high-grade dysplasia in a known case of carcinoma rectum. Snare polypectomy was done. And in 2026 now, a routine ultrasound abdomen and pelvis, the patient did not have any complaints. A routine ultrasound abdomen and pelvis showed thickened endometrium and right head neck cells. Transvaginal sonography showed thickened fluid-filled endometrium with polyp. It was suggestive of T2 heterogeneously high. MRI, actually, we have the images. Dr. Chaitanya, can you please tell us the MRI findings here?
So on MRI, there is a T2 intermediate signal intensity lesion, approximately measuring 37 into 30 mm, involving the right lateral aspect of the endometrial cavity with myometrial invasion of more than 50%. At focal area, it is almost reaching just short of serosa. It is showing diffusion restriction with ADC mismatch. On post-contrast dynamic scan, it is hypoenhancing in relation to the adjacent myometrium, which clearly indicates it's a primary uterine tumor rather than a deposit from a previous CA rectum.
Okay. In such cases, madam, where there is already rectal cancer earlier and again there were high-grade polyps and now with an endometrium, if we are suspecting Lynch, what are all the other tumors that you look for?
Yeah, ideally they need a whole CT abdomen with contrast, proper evaluating the whole GIT, GUT, solid organs like pancreas.
Okay. Dr. Prithvi, lots of questions for you in this.
Yes.
So given that it was initially T3N1, retrospectively, would you have considered a TNT? Because the patient received 1 Kepox and underwent chemoradiation and then they had a residual disease. Would TNT have been a better approach in that case?
I would like to know further details. What was the DFI, for the recurrence? And was it within the, close to the anastomotic site?
Anastomotics, because this was done outside, I just have the reports. The DFI 2018-19 was when it was initial presentation and surgery. 2022 was the polyp and snare polypectomy. So a good 3 years. And now in 2026, endometrium.
Yeah, but I think if 2019 was the date of surgery, I mean, the adjuvant chemotherapy would have continued for 6 months more. Then that puts into less than 2 years DFI actually, with the completion of adjuvant chemo. And
no, the problem was in this case, they received only 3 cycles of Capox adjuvant.
they didn't complete the treatment.
They didn't complete the treatment.
Yeah, so I would actually, why the reason for my asking of these questions is that I would just like to know, is this a new primary because of the Lynch syndrome, which is coming in the already mutated colorectal mucosa, or is it the
Our
local?
radiologist opines so.
Okay, or I would just like to see, because in some cases when there is early recurrence, which is not the standard norm in case of surgeries, would be actually the distal margin, which most of the people would not take. Actually, you need a good 5 centimeter margin cuff, which is a pathological margin. So you should have a surgical margin of nothing less than 6 to 7 centimeters to get a pathological margin of 5 centimeters. Only then you will reduce the local recurrence in these cases. Otherwise, they would present like this, and that would be a surgical failure actually. And the earlier character, this CT3N1, actually, it is a masquerading thing. It doesn't give the clear-cut details about the MRF involvement, EMVI, tumor node deposits. So looking at just CT3N1, one should not be mistaken that this is a very good biological tumor. You have to put in many other things which will come up in the new additions of AJCC, whether these are the factors which actually play much better role in rectal cancer management than just T and N staging. So was there EMVA in this patient?
Actually, none of them were reported. The patient could only produce few reports, and in them, I did not have any information regarding the MRF or EMVI.
So I would just again want to reiterate that unless until patient shows me that she's a high potency for distant mets, I would never go for TNT, as would agree with my medical oncologist. No Rapido, no Produce 23 trial is going to make me to go for induction or consolidation chemo because of the criticisms. And because there is a Lynch syndrome, probably I would like to get evaluated everything before going in. Because if that is a Lynch syndrome patient, then I would have to decide whether I'm going to go for extended resections or segmental resections, depending on the patient's age and the quality of life after. Definitely not TNT if I do not have the full details.
Noted. And this also emphasizes the importance of radiology during this multidisciplinary decision making.
Yes.
And in this case, where they had the metachronous descending colon tubulovillous adenoma with high-grade dysplasia, should segmental colectomy have been considered instead of polypectomy in the background of rectal cancer?
So the problem with this huge, I think this polypoidal lesion is 3 point something centimeters, right?
Yes.
So, and it is not a pedunculated lesion, right?
Yes.
Yeah. So in this
tubulovillous.
Tubulovillous and TVA with high-grade dysplasia, the tumor morphology is so heterogeneous that you will not be able to pick up that invasive part in the in the biopsies. So you might always be mistaken that biopsy showing no invasion is not always a result that it is not an invasion. But once you completely remove it, it might be proven that there will be a focus of invasion. So that is what one has to keep in mind. And if it is proven Lynch syndrome, I'm going to sit with the patient, discuss at length whether I'm going to go for a segmental colectomy of this part, because my goal is not just to remove that part of the tumor and say that you have a tumor, I have removed it, which is more ear pleasing. I would like to sit with her, discuss whether she would require a extended colectomy because all the other mucosa is also mutated. So that will be my first point of contention. And that will be a at-length discussion with my medical oncologist, radiologist, and a shared decision making, which is most important in this kind of patients, because she's also having probably endometrial carcinoma.
Okay. In the current setting of endometrial carcinoma with more than 50% myometrial invasion, would what kind of lymph nodal staging would you advocate? Sentinel versus full dissection or any further surgical staging?
So if I've decided that if I have done a colonoscopy and there are no other polyps in HNPCs, it can be still less than 5 polyps, and I'm going to go for extended dissection, then a simple sample pelvic lymph node dissection will not cause any trouble, because there is already breach of the lymphatics at that area with regards to the prior surgery. Then the sentinel lymph node might actually not have the full value in a naive case where the lymphatics will be intact. I do not know what the surgeon has operated initially, whether he has breached the lymphatics. In that case, sentinel lymph node identification will not be problematic and it will not be representative sentinel lymph node. Then if I'm doing an extended surgery, doing that extra bilateral pelvic lymph node is not going to add any extra morbidity, then I would like to have full template dissections to make sure that patient have a long quality of life rather than just going by a mere protocolized that I'll just do sentinel lymph node dissection.
And given the dual primaries where the patient had rectal lesion and now endometrium, and if we have proven Lynch in such a case, would you consider the extended colectomy prophylactically?
Yeah. Definitely, I would consider extended colectomy. I will counsel the patient because if the radiologist says to me that this is a metachronous lesion within a very short period, that means I would like to know that there are more tumors which are going to prop up if I do a segmental colectomy. Patient cannot be subjected to surgeries multiple times just because we can. I think less number of interventions and more quality of life is the norm actually.
And if this patient, and now if this is a second primary and there are less than 5 polyps or only around 5 polyps, even then, would you advocate that?
The location of the polyps, number of polyps, whether they are located in the tumor proximal to the polypoid lesion or in the distal rectum. If it is less than 5 polyps, only in the proximal area, then I would offer a just extended colectomy without touching the rectum. But if there is more number of rectal polyps which are very bad appearing, and the quality of those polyps will make me to decide even removing total proctocolectomy and mucosal stripping also. So we will require further details and the the expectation of the patient and the quality of life she is going to have post colectomy is what decides the actual treatment.
Great. Dr. Charan, given the second malignancy is endometrium, does the prior pelvic irradiation impact adjuvant RT decisions now? Would there be any dose constraints or toxicity overlap?
So I don't prepare again radiation to the pelvis, but I can consider some brachytherapy by vaginal cylinder. So that will be more accurate than giving a re-irradiation in this setting.
Okay, so I guess that answers the next questions too. Because if pelvic recurrence occurs, re-radiation it becomes a limitation.
Yeah. So in such a case, when there is no radiation which is contemplated in the adjuvant setting, my radiation oncologist is going to tell me upfront that this will be his concern. Then in that case, definitely full template pelvic lymph node dissection, extra vaginal cuff, and the para-aortic lymph node dissection above the IMA till the left renal vein to make sure that there is no skip metastasis, there are no lymph nodes which are left unnoticed. Those extensive surgeries will help us to maintain the same disease-free interval or control of the disease even without radiation, because these are the sites which she is going to recur from the endometrium, although the killer here is colon rather than endometrium.
Okay. Dr. Ravi, I know you already agree that this was suboptimal treatment and the patient should have received a full course of Capox in the adjuvant scenario. And I wanted to ask this question to both the surgeons as well as the medical oncologists. For all the GI malignancies, now we have reflex testing of MSI. Is that being done for all of your cases?
See, in the colon cases, whatever that Indian data has says, it is hardly like 10 to 15%. This is in total of the colorectal. But if you specifically ask about the rectum, if I remember correctly, it is hardly less than 3 to 4%. Yes, we are doing it, but I don't think it will change the management in majority of the patients.
No, but is it being done for every case?
Yeah, universal testing by MMR is mandatory by NICE guidelines since long, and we are following it for all the cases.
Okay. So now this case, if we have proven it is Lynch, would you consider immunotherapy? Like DOSTA, now they have told they have limitation for radiation. Would you consider any immunotherapy?
Yeah, definitely. So if MSI high is there, we can consider, though the data numbers are very less. I think the follow-up is yet to come. I think almost like thrice the number now they have recruited. Initial paper, if I remember correctly, 16 patients, if I'm not wrong. But now it has gone to almost like 98 or 80 patients, I guess. So definitely, but as I said, like the incidence is very, very low.
Yes. So that winds up my case discussions. I hope rectal cancer is very vast and every case is unique in its own way and requires this multidisciplinary approach as we have seen in this discussion so far. So whatever I thought I could give some clarity, I could in these 4 cases I have tried. It has been very interesting and I have certainly learned a lot from my surgical and radiation colleagues. I hope this session was informative to the others as well, and thank you for this opportunity.
Thank you, Hemant and Meena.
That was a wonderful moderation and discussion by the panelists and Dr. Meena. So this reminded me of the MDT from my PG days, graduation days. I think every institute should have an MDT like this.
Thank you, sir.
Every center should have an MDT like this. Thank you. Thank you.
Thank you, Dr. Meena. Thank you, Dr. Hemant.
Thank you.
Thank you. Thank you for this opportunity.
And a small announcement. Actually, the moderator for the next session, Dr. Krupa, she could not able to join us today because of a last-minute personal emergency. So, with the permission of the panel doctors, we'll call off the next session.
So thank you for everyone for sharing your valuable perspectives. I request participants to post their question in the chat box and I will direct them to the respective faculty. Okay, so as we come to the end of today's session, I would like to extend my sincere gratitude to our program director, all our esteemed speakers and panelists, and all the participants for joining us today. Thank you all for your time and participation. All the participation will be receiving certificate 4 to 5 working days to your registered mail ID. We look forward to your participation in future IAIO academic initiative. Have a great evening ahead. Thank you, everyone.